project, Health Equity for Reentering Ohioans. I didn't quite get to the part yet that says we're recording, but we're recording. So hopefully everyone's okay with that. The Health Equity for Reentering Ohioans project is working to address some of the barriers to successful reentry set up by the fact that access to healthcare is more difficult after leaving incarceration. And we are very excited to welcome Dan Mistak today to talk with us about breaking news on the 1115 waivers recommended by CMS, and also just about the issues with access to healthcare during and after incarceration. So I will turn it over to him unless there's anything anyone else wants me to address. All right, Dan, the floor is yours.
All right, hi everyone. I'm gonna share my screen here really quickly. Get that going. And it is nice to see some of you for the first time, some of you for, this is a few times that we met, but I want to say just by introduction that I'm really grateful to be here and to be able to share what I've been working on with my nonprofit coaches for a while. Just want to let you all know I am from Ohio. I live back in Ohio after 20 years away. I'm a prodigal son of Ohio. And I have been working at a nonprofit called Community Oriented Correctional Health Services, or COACHES, for the last 10 years, been working on these issues around Medicaid policy for people involved with the justice system. I took a short 2-year sabbatical where I was providing legal services at a medical legal partnership at the West Hawaii Community Health Center, and most recently moved back to Ohio from there. So I have a deep abiding love for legal services and for just what you all are doing, and I absolutely love it. And I actually really I wish that there was like a perfect mix of being able to do policy work 25 to 50% of the time, and then going back to doing direct services the other part of the time. So I'm just grateful to be able to share with you all. And being back in Ohio, I'm also really grateful for the chance to figure out where I can plug in here. It's really important to me to be able to support the work that's being done here in my own backyard. So I live over in Ashtabula County and still have to, of course, travel a lot and Zoom a lot for work. But I'm really grateful that this is my home base now and for the rest of my life. So I'm really excited not to be renting off of anybody anymore too, which is a nice new feeling. Today, what I'm hoping we can talk about, though, is we want to talk about some major changes that's happening around Medicaid for people who are involved with the justice system. And to do that, I want to set the table by talking about, who does our criminal legal systems operate on, going through some of the health the health profile, and also just the profile in general of folks who are involved with justice systems. And then to be able to talk about how do current Medicaid policies create structural barriers to coordinating care across both health and justice systems. There are some major historical barriers that have just been in place since the 1960s, but we are actually seeing major changes happen to those barriers, and they are happening at a really rapid pace. So for a long time, these laws have been around since the 60s, but starting in December, we kicked off some major changes, statutory changes, and then in January, and then last month, two big regulatory changes happened. And so we'll be talking about that. And then finally, if we get to it too, because this is a lot of information to try and go through, and we can more than happy to share this slides on the other side to talk about how we could actually model this relationship between health and justice systems. What are the things that are out there that allow us to kind of get a grip on how the justice systems operate and where health interventions could be useful for that. But I want to say during all of this, there's only like 10 people here, and I think 3 of you have already heard me talk about a lot of this before. I would love it if you would ask questions during this. And I would just really love to know at the beginning, I don't know, maybe you could put your hand up or something, or you could do a little one of the little emojis. If you're here from the health world, is anybody here like a health practitioner in the health world trying to figure out how they can be a part of this? Just go ahead and do a clapping emoji or something. All right, we've got at least one. And then if you're an attorney, could you do the like crying emoji? Is that one a possibility? Do we have that one? All right, crying. Yeah. All right. So we've got a lot of attorneys here. Great. And then the rest of you, by all means, feel free to put in the chat where you're coming here from, because I would love to be able to make sure that I might be tapping into some of your what you're interested in. Of course, in my process of doing this, I like messed up my screen now and can't. There we go. I got it off to the side. I'm just gonna look at this chat. Great. We've got folks at the public defender. I love it. Community-based social workers and from the health department. This is great because here's the situation as we see it, is that the justice system exists as it does, not because we treat it as something that's separate from the rest of our systems. But in reality, all of these systems interplay with one another. And so Coach's goal, we come at this from the point of view, we were created by some health folks back in 2005, was to say, look, if we're trying to support people's care wherever they receive it, what we want to do is make sure that we're integrating that care across all of the different locations where they receive it, whether it's a nursing home or a clinic or a hospital, physician's office. But one of the major places that we've left out when we're thinking about it is jails. And like it or not, and frankly, we don't like it, people receive care inside of jails. And that care inside of jails ends up being episodic and siloed from the rest of the health systems, which really gets in the way of us being able to create a system of care for folks to receive care wherever, to be able to receive integrated care wherever they're actually, whatever setting they're receiving care in. So what we try and do is build stronger health systems by trying to increase coverage and, reach all these like health goals of population health and integration and lowering costs. But really what we're trying to do is to figure out how to support criminal justice system reforms, reduce recidivism, and improve public safety. But at the same time, making sure that we are talking about the significant racial disparities in both our health and our justice systems that make our systems the way that they are right now. We have health disparities, we have justice disparities, and those things are mutually reinforcing to one another. So what's the lens that we can look at this through in order to try and elevate and remove those disparities in both systems? So like I said, Coaches was started in 2005. I've been working in one way or another with Coaches since 2013, volunteering, and then ended up getting sucked into the Borg in about 2013. And like I said, been with them except for the 2-year hiatus when I was in Hawaii on creating the medical legal partnership. But we work with community partners to provide technical assistance for what it could look like to connect health and justice systems together. A lot of that involves a lot of health information technology work, connecting in electronic health records and health information exchanges so we can just understand better what's going on with folks in the justice system. And then also working on policies. So we've been working on these 1115 waiver policies for a long time, and we'll dive into what that means more later on, but also just helping local justice systems develop policies in the wake of what's happening at the federal government, helping state policy folks figure out what's going on in the wake of the federal government, and also helping the federal government develop these policies. I've been very lucky to have been pulled into meetings at all of these different levels in order to try and identify policy barriers. And finally, one of the things that I really do enjoy doing, and I know that like every nonprofit does it as parts of the convening industrial complex, is to try and convene folks to talk about these things. But the truth is that health and justice partners really rarely talk to one another. They don't even speak the same language. And so it's really great to get people in the same room and realizing, oh, we've actually been dealing with the same clients, but we haven't been talking about it. And what are the tools that each of us has to actually be able to share information and to help people get out of the justice system and into much more appropriate settings. So one of the things that's important and drives the work is to obviously understand that providing care in the jail is providing care inside of a major silo. And that's incredibly unfortunate because jails are, which is completely cliche, but is what everybody says and what is completely true, is that jails are the de facto behavioral health providers for a lot of people who are pretty chronically underserved by our health systems. And on top of that, they're not just the de facto behavioral health providers, they're cut off from a lot of the health providers in the community as well. and jails have a pretty challenging job to do when it comes to helping support folks who are coming inside of the jail. And that's because they have to do the work basically of a behavioral health emergency room. They receive patients at all hours of the day. They know very little about them. And they have to triage very quickly to understand whether or not somebody is in the midst of their first mental health crisis, whether or not they might be experiencing a meth-induced psychosis, or whether or not this is someone dangerous who needs to be kept from everyone else. That is incredible stress on jail staff, and it's also an incredible stress on the people inside the system. So often when I'm saying justice involved, I hope it becomes clear over time that I'm talking about not just the people who are incarcerated, but also the people who work inside of these facilities, because we really have a crisis on both sides of the bars. People who work inside of jails are often faced with a really challenging, like I said, just a really challenging task of trying to identify what someone's health condition is. And this is why we have so many people who die behind bars too, because they just are not able to get the care that's appropriate, medically appropriate for them. And jails are mostly focused first and foremost on safety of staff. And so that results in really some non-clinical decision making driving what's going on. Jail, like I said, jail care also is episodic and siloed from the broader set of health providers. If you receive treatment in the community, hopefully, right, in an ideal healthcare system setting, we don't live in that ideal healthcare system setting though, but care would be shared across a variety of providers so that you could have a better understanding of what goes on. If you see one provider here, one specialist here, able to understand and communicate with one another so that you're getting the right kind of care. On the other hand, though, what happens in a jail is you come in, you are getting whatever treatment they're offering you, then you're sent out into the community, and nobody really gets information of what might be happening there. Of course, different jurisdictions do this differently and try and do it better, but there isn't a lot of communication inside and out. Also, healthcare infrastructure, like the things that we really count on inside of our healthcare system, just doesn't necessarily exist inside of the jail. There really isn't oversight, quality measurements, things like medical necessity are not a part of the decision making, and there's not a lot of transparency. So the quality of care, the expectations inside of jails just doesn't align with what we expect for community providers. And like I said before, a lot of the decisions are driven mostly by correctional and not clinical needs. So, all of this ends up creating not just negative impacts for the individual who's inside of the justice system, but it also can lead them to not getting the underlying condition treated that might have led them to the justice system to begin with. And then, I'm sorry, it was flashing in my mind thinking about what just happened in New York City, to think about the individual who was strangled to death on the subway. And this was someone who was very clearly not having his needs met by the system at large. And there were plenty of opportunities for intervention in supporting him in his life. And it just never happened. And so what happens is we get these negative outcomes. We get people rearrested time and time again for untreated mental health conditions. That's incredibly costly, if for no other reason, besides like the extreme moral imperative to try and help folks involved with the justice system and just help people with behavioral health conditions in general. We, we can appeal to people who are making these decisions based on how costly it is. And this is according to public safety officials. This is the people who are, one might assume is doesn't have alignment with what the behavioral health system in the community wants, or behavioral health providers want. So they really see this problem too. So there's a lot of actual common interest in trying to make sure folks don't end up inside of the jail who have untreated conditions, and that we can provide off-ramps for them and better connection to community health systems. So that's just kind of the intro into the jails are basically not therapeutic environments, and there's reasons for that we're going to get into more. But I think it's really important to talk about the health profile and the profile of people who do get involved in criminal legal systems more broadly, so that we can kind of keep an eye on who do these systems operate on right now. So one of the major things is that people who are incarcerated are disproportionately poor. So here we can look at the data here and just see that folks who are incarcerated are almost universally poor enough to qualify for Medicaid. They are much poorer than non-incarcerated people on the outside. And we can also see that there's major racial disparities too when we look at it, when we look at the income differential here as well. So the jails primarily are housing people who are poor and people of color. In addition to this, obviously being incarcerated over and over again, people face high rates of unemployment, causes instability in employment, instability in housing, which of course can lead to homelessness, can lead to family law challenges. So the jail ends up being one of these social determinants of health. And it's one that we don't think of as a social determinant of health because we kind of place it inside of the category of being about criminal right and wrong, moral value, moral right and wrong. When really the jail itself is an incredibly destabilizing, going to jail is incredibly destabilizing and leads to all of these other consequences too, that then we criminalize and treat people as being undeserving because they aren't employed and they can't find housing. And so it just becomes this incredible cycle of destitution and deprivation. Also, people who are incarcerated generally have lower rates of education and literacy, which is really interesting when we're trying to think of how we can support people who are coming out. I work with some reentry folks in Hawaii still, and they wanted to put together cards for folks who are leaving incarceration so that they can call certain numbers to be able to have their health needs met. But the majority, shockingly, majority of people who are incarcerated in Hawaii are either have low levels of literacy or are illiterate based on the definitions of literacy in Hawaii. So it's we have to think about interventions that are also supporting people. Unsurprisingly, we know that jails are disproportionately incarcerate Black Americans, American Indian, Alaska Natives. That if we are really thinking about jails, they are places where racism has really shaped how and who has entered into these facilities. You might say, well, the Hispanic population, though, that's much, much lower. This does not account for any of any sort of immigration detention or things like that too, which would, obviously vastly change these numbers. People who are incarcerated also have much higher rates of infectious disease and chronic infections. They have high blood pressure and tuberculosis, hepatitis, HIV/AIDS at rates that are much higher than the general population. And the thing is that the health conditions that exist inside of jails and prisons don't stay there. 94% of people who are incarcerated are going to come back to the community at some point. So this is when we're treat jails and prisons as though they are kind of separate from the rest of our health system. The truth is that they're places where people are temporarily displaced, and the health conditions that are there don't just remain there, but they also move back and forth into the community and back. And we obviously saw this during COVID-19 as well, and continue to see this during COVID-19 as people who are incarcerated have much higher rates of COVID infections and also of death from COVID in serious cases. Mental health and substance use disorder are also much higher inside of jails than in jails and prisons than in the community at large. These are comparing to between jails and prisons, which is interesting. So jails, are temporary places where people end up being incarcerated, while prisons, on the other hand, are places where people are typically sentenced for more than a year. So you can see people who have some pretty serious mental health needs end up coming into the jail often. Once people are in prison, it's a little bit lower statistic, but also it's very interesting too because significant numbers of folks who are incarcerated just never have the chance to receive a diagnosis of a mental health condition at all, anyways, because they've probably never seen or may not have seen a provider in the community. And then, of course, people who are leaving incarceration are, which is why the Hero Project is so cool and why I really am happy that it exists, is that people who are leaving incarceration are it's a pretty critical health moment. So people who are leaving incarceration have health needs that really need to be supported at that moment. It's like being discharged from the hospital without any sort of care plan. We would never do that. It's such a huge challenge. So why is there? Yeah, Sonia, excellent question on data. I'll get to that in a second. People who are leaving incarceration are 12 times more likely to die in 2 weeks following a release, or 120 times more likely to die of an overdose. That data was out of Washington, and Massachusetts also has a similar data set that shows the same thing. So yeah, is there more recent data? The answer is no, unfortunately. There is a study out of North Carolina where they looked at opiate deaths upon release, but there's an incredible amount of challenge with actually doing research around health and incarceration. The National Institutes of Jails actually right now has an RFP released in order to do some research around jail healthcare, because there just isn't much done around there. And I was in a PhD program and really left because I was having such a hard time with getting through the institutional review board process, which makes sense, right? We don't want to be doing necessarily research on vulnerable populations without a really high standard, because of the Tuskegee experiments where we tested on like gave folks syphilis, Black people syphilis, in order to see what the course of that infection was, or withheld. We really withheld treatment from folks with syphilis, Black folks with syphilis, in order to see what the course of the disease would do. And since then, we've created these institutional review boards in order to protect vulnerable communities. But now a lot of times what that's meant is that people just don't do the research anymore. So there really isn't any research. Last time an ethnography was done in the jail was 1985 in a book called John Irwin, or a book by John Irwin called The Jail, where it talked about what it was like for folks in the jail by interviewing folks in the San Francisco County Jail. And since then, there hasn't really been any in-depth ethnography on folks who are in jail. And there is just not a ton of research done on people who are leaving, although there is some more data now, but there isn't much. There's unfortunately not much, which is a huge challenge for being able to put together an understanding of what would work for as health modalities for people who are leaving incarceration. Also should note that, and again, this is the 80% of detainees, of people who are detained. Sorry, that is something I've got to change there. But people who are incarcerated with a chronic medical condition haven't received treatment in the community prior to their arrest. That was pre-ACA data. So hopefully that number is getting smaller, but that study hasn't been done again since then. So since I mentioned the ACA, this is a great time to segue into Medicaid policy, but does anybody have any questions sort of about the health profile or even the data on any of the things I've talked about so far? No worries if not either. But so the next part is going to be maybe a little nerdy, and I know a lot of folks. I am currently writing a paper with for my old colleagues at Legal Aid Society of Hawaii, in order to help them kind of understand Medicaid from a different angle. Obviously, you know, many of you are working with Medicaid all the time, helping people get enrolled, might be, you know, appealing negative decisions about people's eligibility for certain benefits. But the actual like Medicaid as a like giant superstructure that shapes our reality is something that at least the folks at Legal Aid Society said we don't have a real grasp on this and to understand its capability for change. This is unfortunately kind of how my brain sometimes thinks about things, which means I'm not very effective at the at the day-to-day stuff. But it's really important, I think, to understand why Medicaid matters now and how Medicaid can be an amazing tool for driving change for people who are leaving the carceral setting. So why Medicaid? How does Medicaid work now? Obviously, Medicaid is the health insurance program for low-income individuals. But before the Affordable Care Act in 2014, basically 90% of people who were incarcerated had no health insurance. I mean, the 10% who were incarcerated were probably like there for 10 minutes and then left because they could also be bailed out. But since 2014, in states that have expanded Medicaid, like Ohio, People who are incarcerated for the most part have access to Medicaid for the first time. So they can receive Medicaid in the community. They can go and see a doctor and have that paid for. They can have some long-term support for some chronic health conditions and have that be paid for. So in a lot of states, and Ohio has actually done a really great job of enrolling folks in Medicaid as they're leaving incarceration. So people come out with being enrolled in Medicaid. There are still challenges with being connected with the pharmacy benefit and being connected with providers, but they have health insurance as they're leaving. Yeah, Larry, I'm going to hit that point on the next one. Larry asked if people lose Medicaid coverage when incarcerated, and we'll touch on that in the next slide. So the next opportunity, though, is to be able to make sure that people can receive Medicaid wherever they are and create continuous coverage across all these systems. Obviously, a single payer system creates a much easier opportunity to integrate and share care across providers. So making sure that there isn't anyone who's carved out, any providers that are carved out of the Medicaid, of the payer program, makes it a lot easier to be able to integrate that care. But we have something called the inmate exclusion, which is inside of the Social Security Act. So I'll touch on that too. We have something called the inmate exclusion. That's actually inside of the Social Security Act, and it says, otherwise Medicaid beneficiary, you are absolutely entitled to Medicaid, unless you're what's called an inmate of a public institution. So what that means is that people who are otherwise eligible for Medicaid, if they are booked into a county jail or sentenced to a prison, would lose their Medicaid access to Medicaid services. So states have tried to figure out how to do this, losing access to Medicaid services in a variety of ways. One of the ways is that they just terminate their Medicaid upon incarceration. They just send that message up to the single state agency, and then they disenroll them from Medicaid. Other ways, they try and suspend Medicaid, but then as Larry noted, people might still have challenges with reinstating Medicaid on the other side of release. So even these sorts of workarounds to try and figure out how we can try and make the time when someone's incarcerated as small as possible still makes it so that a person who's incarcerated faces major hurdles to get their Medicaid turned back on upon release. And the reason why this existed was to prevent cost shifting to the federal government, basically. They didn't want folks to be in jail and then have all of the costs associated with the healthcare provision inside of that facility to be shifted to the federal government. There's also something called the Institutions of Mental Disease Exclusion, the IMD exclusion, which has been waived since 2015 for states who want to do it. But that was for people who need residential treatment, mental health or substance use treatment. So those two populations were excluded from receiving Medicaid, even though they'd be eligible beneficiaries. And that was mainly to try and stop folks from being able to from cost shifting to the federal government. So this continues, as I said, ideally, we want to be able to make sure that people who are receiving care are able to receive it at the same quality and same level of oversight wherever they receive it, whether that be in a nursing home or a hospital or at a FQHC. But the jails have been left out of that, which means that the care that's received there, again, episodic, disconnected from everything else. That leaves providers on the outside trying to scramble to figure out, was this person on MAT? Were they receiving the psychotropic medication that keeps them supported? Were they getting case management? Is their blood pressure managed? Are they getting the same meds while they're in jail? All of that's a major, major question mark. So Shelby Shields asked, how long do they get to have insurance after they're released? So Medicaid, as long as somebody maintains their Medicaid eligibility, which means they continue to make below 138% of the federal poverty line, or they still continue to meet the health criteria or the health-based ways that they qualify for Medicaid, they can maintain their Medicaid coverage. There are redeterminations that happen, but as long as someone's a Medicaid beneficiary, as long as they're going through their redeterminations, they maintain their Medicaid for forever. So the inmate exclusion creates a pretty major problem for those of us who are interested in trying to create a health system that supports people who are involved with the justice system. But Medicaid, of course, can be a really important way that people are supported on through as they're leaving the justice system. It's incredibly important for people who are leaving. And it's also really important for those of you healthcare providers in the community in order to try and make sure that you're creating a system that works for the people that you're trying to see, and that you don't lose the investments that you've made in that individual's life. So Medicaid could really change the way that things work inside of the justice system. It could actually allow for us to create, for the first time ever, systems that cross correctional community providers and have it be the same payer in the level of care, which Medicaid has actual standards of care. A lot of jails don't necessarily. A lot of that's litigation driven that decides what the policies and procedures are inside of the jail. So having Medicaid in the jail provides us the opportunity to align the community health standards and correctional health standards, which means bringing processes in for oversight and accreditation and transparency, which will allow the decisions that are made inside of the jail to be a little bit different than what they are right now. Right now, like I said before, it's a lot of corrections driven. Well, that's because the corrections aspect is where the money comes from and what is going to really drive how those decisions are made. But if actually Medicaid is a payer inside of these facilities, in order to be able to receive those Medicaid dollars, decisions have to be made by clinical decision making, rather than correctional decision making. So it also would have a huge impact on the quality and program integrity that it's offered inside of the jail, and it would also allow for recalibration. The feds might call it cost shifting, but I call it a recalibration of the financial responsibilities, because as it is right now, it becomes incredibly expensive to treat people who are incarcerated, and it doesn't end up being a real great investment. But if Medicaid could be the payer, then it would preserve those investments that were made in the lives of people who are involved with the justice system. But also, really importantly, too, it creates leverage for points of future change. The jurisprudence around an individual as a Medicaid beneficiary is significantly different than the jurisprudence for folks who are involved with the justice system, where basically the standard is that the care that's provided can't be deliberately indifferent to the serious medical needs of a person who's incarcerated. So what does the future look like, and what are the big changes that I was hinting at? Well, just in April, like last month, a long awaited set of guidance from the Centers for Medicare and Medicaid Services in a letter that's called Opportunities to Test Transition-Related Strategies to Support Community Reentry and Improve Care Transitions for Individuals Who Are Incarcerated, was released from CMS. And that would invites states to apply for waivers of the inmate exclusion under certain conditions. So basically what's happening is the federal government is saying to the states, saying, look, we know that this has been a real problem for you who are trying to create systems of care for folks, and also trying to really combat the opioid epidemic. So we are going to allow you now to waive that inmate exclusion, to request a waiver of the inmate exclusion, but you have to tell us how you're going to do it and what you're going to do. So states can request basically the full set of benefits to be offered inside of a jail right now, or they could decide to offer a targeted set of benefits. They could ask the federal government to allow them to provide it to all Medicaid beneficiaries, or they could also ask the federal government to provide a set of benefits to just folks with SUD or folks with mental health needs. And so however a state decides to cut it, there are three things that must be included inside of any waiver. The first is medication-assisted therapy, obviously, because this is a big push for this has been the opioid epidemic. So we want to make sure that MAT is allowed to be either started or continued while people are incarcerated. There also needs to be 30 days of bridge medication because, like I mentioned earlier, it's been a huge challenge for folks who are released to get their Medicaid benefits turned on and then also get them the prescription benefit turned on. So that creates huge barriers for folks who are leaving the justice system to make sure that they get their medication. So 30 days of bridge medication provides a real opportunity to kind of get through some of those major challenges, get people in to see a provider, and then to be able to have them get their prescription more normally through the normal means. One of the other major things too is that each of these waivers has to include case management. Huge questions about what the benefits would look like, right? Case management can really look differently based on what other based on what people are asking for. Felicia asks a really good question. Is this process up to the institution to apply for this waiver? What is the likelihood that these institutions would opt into this? So it is actually up to the states to apply for this waiver. So the state Medicaid agency is the one who would be applying for this agency. It's called an 1115 waiver. There's actually been an incredible amount of support from different sheriffs across the country for these types of waivers. So it really is going to depend upon a few things. One is, how much would a local sheriff understand that this is going to save them tons and tons of money, actually, because right now they're paying for this out of their budgets. They're also sort of accepting responsibility because they're contracting with healthcare providers who may or may not be providing quality service, and those services end up costing them in litigation if they don't end up meeting the right kinds of standards. So, and I have no idea whether or not Ohio is going to be applying for this waiver. I wish I knew. I'm new back new to the state. November, I just moved into my house in Andover, so this is really new to a lot of the ins and outs. The secrets of Ohio are not yet revealed to me. So other things that might be of interest, it really depends on whether or not a sheriff would be interested in, whether or not they see like the value in this, right? So there's a major pitch to make to a local facility, because honestly, none of this will work without the buy-in from the sheriffs or whoever is running the facilities, right? I understand that they're not all run by sheriffs. So it really matters who is doing this. So I should also say that the waiver of the inmate exclusion is for up to 90 days before release. So for people who are incarcerated in jails, for the most part, that's going to be the entire time that they're incarcerated. Obviously, the prison folks are there for a lot longer, but that 90 days is incredibly important for those connections back to the community, wherever people might be returning to. So it's not, one of the things I want to say about this too, it's not just cost shifting, right? It is an opportunity to create a different health and justice system. So in this guidance, what CMS has said is that, look, we don't want you to just say, okay, we've been paying for these health services for so long, for forever. Now we're just going to have Medicaid pay for those services. Actually, what Medicaid says is, no, you've still got to actually put out the same amount of money, but now you've got to reinvest the savings into creating or enhancing whatever health systems exist already. So it can be to divert somebody from the justice system. It can be to really enhance and build out the type of services that are offered in jail. It can be to do things like non-emergency transport for somebody. So if somebody is, taken to a jail and you're like, well, this person doesn't belong here, one could reimagine the state reinvesting those dollars, or a jurisdiction reinvesting those dollars, to say, okay, we're going to have someone on standby who is going to be able to drive that individual to a more appropriate setting. Perhaps there's a crisis respite center or something else that might be more appropriate for that individual. These are the types of systems that can be rebuilt, because right now a local jurisdiction pays millions of dollars for healthcare inside of a jail setting. Those millions of dollars could be now diverted or reinvested into different programs that could support people. So it is, what I say is, this is a real chance to come together and rethink what this would look like, what our justice system would look like, and what our expectations are for the justice system. I mean, it's like, I know you all have never heard of me before, never seen me before. Like, this is such a world-shattering opportunity. I was told that this would nothing like this would ever happen in my life, and I was told this when I was just a youngster in my 30s, and now I'm getting older, and it's happening. It's bipartisan, and it has support across the board, from sheriffs to community organizations. It's something that we could really leverage into major change for how our justice systems operate. But it really depends on all of us actually being a part of that conversation, and getting the state to support something like this. But besides that change, it's not just it's not just this guidance that has been really huge. There's also been some statutory changes. So the guidance, gives the state the option to kind of decide to bring Medicaid inside of these facilities. There was a statute change in December that doesn't give the state the option to make a difference, to make a change there. So there's two sections inside of the omnibus appropriations law that I think are really interesting. The first one is section 5121. I'm going out of order. I don't know why I did this. By the way, this is my first time presenting on this, like as things have now happened. It's always been like, this is what could happen. Well, this is like, we're in a new world now where I'm trying to talk about what has happened. So section 5121 of the omnibus appropriations law requires screening and diagnosis. So the Medicaid benefit for juveniles is called EPSDT, early periodic screening and diagnosis and treatment. So the S and the D part of that benefit for juveniles is now required in January 2025 because it passed in December, but it's not going to be implemented until January 1 of 2025. So the state has to grapple with right now, what would it look like to bring Medicaid inside of these systems? So now screening and diagnosis is required for juveniles 30 days before release. There is not common language between our carceral systems and our health system. So when Medicaid says juveniles, that doesn't mean juvenile justice system. It means anyone who fits the definition of a Medicaid juvenile. I don't know how Ohio has defined it. States have some flexibility in doing that, to what age, but for a lot of states, you're considered a juvenile for Medicaid purposes up to the age of 21. If you were in the foster system and aged out of the foster system, you could be considered a juvenile up to the age of 24. So it really is those individuals could be incarcerated in a jail. It doesn't mean that they have to be inside of a juvenile justice facility. So jails are going to have to grapple with Medicaid inside of their facilities and be able to identify who is a juvenile if they're enrolled in Medicaid, and then how to get them, who's going to be the provider for these services. This is huge. And I don't know that too many jurisdictions are thinking about it yet, or would even know how to start grappling with this. It also requires 30 days of enhanced case management, which is a targeted case management, which is a specific Medicaid benefit, 30 days before and after release. No ifs, ands, or buts about it. They've got to start offering targeted case management 30 days before release and after, starting in January 21-25. Then section 5122 would even, this one allows states to expand it even further and allow for Medicaid benefits to be maintained for unsentenced juveniles who are pending disposition. And like I said, juvenile is a Medicaid definition here. This is not about who's inside of each of these. Sonia asks, is funding allocated at 5121 Medicaid? Absolutely. It is just a part of the Medicaid spending. So it's the Medicaid appropriation. There's no special need for appropriations for just this section. It is the part of the regular Medicaid appropriation. This is 5121 is non-optional. 5122 would be optional for this state to do it. And also, the state would only have to pay its percentage of it because the federal government's already would be paying the other part of the FMAP, which is their percentage that they pay. So that's already law of the land. There's also more laws that are being considered right now. The Medicaid Reentry Act is one I'm going to highlight because it has co-sponsors. This two Senate co-sponsors are Senators Brown and Vance. They're two of the co-sponsors. They're both of our senators. Representative Joyce is also a co-sponsor, and so is Representative Turner. So these has a pretty strong Ohio presence. But the more Ohio folks on board, of course, the more it means for us here to be able to make it a reality once the law is passed. But the Medicaid Reentry Act would essentially change the statute, the Medicaid statute. So it wouldn't be this sort of executive branch regulatory way of doing it, but it would change the statute to allow for Medicaid benefits for eligible justice-involved individuals 30 days before release from incarceration. So this has passed the House many, many times, but has been kicked out because of just absolutely the most annoying and boring bureaucratic reasons that involve things like parliamentarians and, the types of things that we don't even know exist inside of our legislative branch until suddenly you're finding out that they're saying it doesn't pass things like the bird bath. All of these things, like, I didn't know that this did not show up on Schoolhouse Rock, but these are the sorts of things that we bump into when these laws are being passed. So this one is, again, Medicaid Reentry Act has been reintroduced. If something like this passed, it'd actually make it a lot easier to be able to apply for the Medicaid waiver for very nerdy reasons, which is that Medicaid waivers have to be cost neutral. Nobody's interested in that, but if you are, feel free to send me an email later, and I will let you all give you all the information that you need to help you fall asleep very quickly at night when reviewing it. So, that was a lot of information. This was the part that I was originally asked to come and talk about. This is very easy to just share with you on the other side of it. I want to make sure that there's time for questions. So, I'm at your disposal. I don't know what would be helpful or not. But basically I'll just show you this slide, and then I will stop for questions along the way. So, often when I'm talking to folks about, how could we possibly do this and what's going on? Well, and instead of trying to boil the ocean, one of the things to do is just say, let's just break it out into pieces to figure out what it could look like. And so SAMHSA, which is the federal agency around substance abuse and mental health, has created something called the Sequential Intercept Model. And what it does is it just tries to break out all the different places where people are involved with the justice system and try and create off-ramps into different community systems. And Medicaid is an incredibly powerful partner for being able to divert people from the justice system or strengthen the community systems all across the board here. So even before all these statutory and regulatory changes have happened, Medicaid could play a really strong presence in being able to help folks get into a better position and out of the justice system where they wouldn't belong to begin with, because they're only there because of their untreated substance use or mental health needs. So you can look at all this all along the way, but here's different places where Medicaid has, and I'll send this to Jen on the other side, and she can pass it along to you. Different places where Medicaid can really do some support for people so they never get involved with the justice system to begin with, Intercept Zero. Or if they are, if law enforcement is called, how are there new Medicaid opportunities around crisis support? How is 988 playing a different role? What about things like Cahoots, which is a model, it's a crisis response model that now is available for Medicaid dollars. It never used to have Medicaid dollars before. You have to apply for it through waiver processes, things like that. And what are different ways in which different deflection or law enforcement diversion programs could actually interface with health partners to divert people? And then once people are incarcerated, what are the different opportunities for people to use peer support or to be screened at a Medicaid level of screening rather than sort of jail screening, which are very different levels of screening, to be able to identify and understand what a person's needs are? How can we really start relying on our courts differently? A lot of courts right now who do specialty court work might be suggesting people take services not because of their clinical profile, but rather because just old relationships, right? And it makes sense. Specialty courts were doing a lot of specialty mental health and substance use work before even Medicaid would pay for some of these services. But now we have the chance to really support specialty courts to step into the future of actually having more clinical decision making, which I think will really strengthen the specialty courts and help them have much better outcomes. Obviously, the jails have massive changes, things I was just talking about, and then of course reentry. Reentry right now is always seen through such a justice-focused lens. Okay, these are the things you have to do in the 12 steps on your way out the door, and this has got to get a job, and here's the people to call for it. But reentry really is a health event. So all of those waivers and things I was talking about, these are all opportunities to have health partners play a much bigger role in making this a reality. And then, of course, inside of probation and parole, there's a lot of things that are done that are disconnected from our broader health system, and that leads to, I think, an impossible amount of work for people who are trying to do their best on probation or parole, and the consequences of failing in those places for doing, frankly, the normal things that are a part of everyone's normal life, like not going to see a doctor when you're supposed to. We get like $25 cancellation fees if we end up not seeing the doctor on a day that we're supposed to. People often end up going back to jail or prison if they don't see a doctor that they were supposed to. So what are the ways that we could actually kind of change that decision making and really bring in a more medical way of thinking about, a clinical way of thinking about what someone's recovery or health needs are, rather than criminalizing the normal expectations for the course of a person's clinical recovery process. So I just blasted lots of information at you. I'll share this with all of you. So just next steps I want to offer. I'm open to more next steps. I'm also open to more conversations with any of you if you want to have deeper dives into any of this. I'm even open to driving out to where you are, coming to meet you, getting in touch with you all in other ways. But I'm going to just continue to be a part of monitoring federal legislation and also looking at state waiver applications. I would love to know what Ohio is doing and to see if I can be a support in any of those processes along the way. Also, it's a really great chance to start establishing relationships yourselves with national and local Medicaid partners in advance of these waivers, right? Together, you have a really strong voice of being able to say what kinds of services ought to be offered. Medicaid has lots of opportunities for engagement from the community. And then also there's lots of opportunities to apply for planning grants from both health and justice partners. Sometimes we only look in one silo or the other, but the Bureau of Justice Assistance, the Office of Justice Programs, Health Resources Service Agency, those are just a few federal agencies that offer money around planning. In fact, I had 2 HRSA grants that we used to support the mapping on the Big Island of Hawaii around our behavioral health network. And you can reach out with any of these things that I mentioned below or more if there's a place where you see that I can fit with what you're trying to do. I'm here at your disposal. This is my email address. I'm also, oh yeah, like I said, more than happy to talk with any of you at all about any of your thoughts on this. And I'm going to stop sharing and then see what Anne has to say. So will coaches start advocating with ODM for the waiver, or do you leave that more to local state entities? I'm more than happy to help support anyone who's interested in advocating for this, or if anyone has insights into what's going on inside of the state, strategizing together at where things are. I mean, by all means, right now I'm working with a group of stakeholders in Hawaii to try and help support them as they want to ask the state for one of these waivers. So I'm here at your disposal on this, but this is something, unless the avenues get open for me to be able to do that, it just ends up I'm not a known quantity yet inside of the state, except for a few folks who are no longer even inside the Medicaid or the corrections program. But anyway, I am here and happy to help where I can.
Okay, so it looks like Larry is trying to make a connection with you, Dan, and so I will get the slides and make sure that those get circulated to everyone. I'm trying to scroll back through and make sure we didn't miss anything, and I don't think we did. Are there any last final questions for Dan or for me or about the Hero Project? I will say, Larry, I saw your one message that you encounter a lot of people who don't get the help they need reinstating or starting Medicaid. Our case acceptance guidelines at Legal Aid are open for that issue, so you can be referring folks to Legal Aid, 888-817-3777 or lasclev.org for help with this issue. That's one of the main issues that the Hero Project team is working on. But yes, and if you're not following the chat, CEUs were approved yesterday. So if you can benefit from those, they are coming your way. There's a recording, we'll get you the slides. Any other questions? All right. Oh, we have one question. Go ahead, the floor is yours.
Well, this is Sonia. Dan, I just want to welcome you back to Ohio. I work at Metro Health, and I think I'm looking forward to getting connected with you. We have a partnership with our local county jail here that's been long-standing, and it's a great opportunity for us. I'm sure our GR team is looking at the 1115 waiver. We've done one of those ourselves in the past that helped then expand Medicaid in Ohio with our Republican governor. So I share your excitement. This is a topic that if most people understood that people's Medicaid was ripped away when they became an inmate, they would say, why? That makes no financial sense, no matter what side of the party, what party you're on. So I'm so glad you're here teaching people about this, and I'm sure Metro will get connected with you and be a collaborator in the future.
Great. Cause some good trouble. Looking forward to it.
Well, if there are no further questions, I just want to thank Dan again publicly for being such a great partner of the Hero Project team and for joining us today. And we'll get those materials out to everyone soon, and enjoy your
one more thing. I'm so sorry, everyone, before you. This is me being stupid and terrible at self-promotion. We just published a bunch of briefs called Beyond the Inmate Exclusion. And what it does is kind of looks at the history of the inmate exclusion policy. And I'm going to pull it up right now and put it in the chat. So it's one kind of overarching brief, but also 9 targeted briefs to different partners inside of the health and justice systems to look kind of beyond good job, Anne, beyond the inmate exclusion. So we're at this space now where we have these waivers, et cetera. But I think what is useful is to look at what horizons are in the future. So where could prosecutors be looking at trying to interface better with the justice system? Where could public defenders be looking to partner more with different folks inside their system? So this came out of a bunch of interviews with different health and justice partners. So there's one overarching brief again that explains how we got here and what a bad policy this is. And then the other ones are looking towards what will it look like when we kind of start biting away at this shadow health system that we've created by erecting this barrier between our health and justice systems, and what could it look like to actually support people and really, frankly, stop criminalizing a lot of people's medical needs. So please look at those two and share with all of your friends and the health and justice partners. Should have said that sooner.
Thank you very much. And thank you all, and enjoy the rest of your Friday. Bye, everybody.